Hello, everyone. It is a pleasure to welcome you on behalf of the European Society of Ophthalmology section for the young ophthalmologists for the webinar, and to welcome you for the webinar on 2AM Emergencies and Sustainability. Before we begin, I would like to run some quick housekeeping items for everyone. So first, I would like to tell you that the audience questions, so you can ask questions via the Q&A, and we will be looking at them and trying to answer as many as possible. If you have any particular question after this webinar that is not answered, please email us to the SOE webinars at soevision.org, and we will try to answer them in a separate document, which will be then assessed via the SOE website. This webinar is being recorded, and we will be able later via the SOE website and placed on the SOE YouTube channel for everyone, so you can again listen and get your notes and everything that you want to learn. I would also just like to talk you through the running order for today. So each talk will be presented consecutively. We have the first 3 talks that will be followed by this discussion for the initial 3 talks. Then the second 3 talks will be followed by the final discussion with the 3 speakers that are involved in this section. If you would like to ask questions, please submit them again via the Q&A section on the Zoom. And now it is my pleasure to open our first part of this webinar, the 2AM Emergencies, and to introduce our first speaker, Professor Murat Hasan-Raisoglu from Istanbul, who will discuss about trauma case and endophthalmitis, the biggest disasters. Please.
Good evening, everyone. Today, I would like to talk about trauma cases and trauma-related endophthalmitis. Of course, these topics are very broad ones, and I would like to touch upon the main aspects of these clinical pictures and give some clues about how to manage those cases. So ocular traumas are like 7% of all injuries are ocular traumas. They're more common in men. They have a bimodal age distribution. They are more common in childhood and then in the young adults. Almost 30 to 40% of monocular blindness cases are ocular traumas, and most importantly, they are preventable with simple precautions. There are many kinds of traumas. The traumas can be like due to terminal radiation injuries, electric injuries, but for the sake of this presentation, I will talk about physical and mechanical traumas with or without retained foreign bodies. So we classify object-inducing injuries into 2 different types, which is one of them is blunt traumas, and if there's a blunt trauma causing full thickness eye wall injury, we cause it a rupture. If the eye wall is unbroken, we cause it a contusion. And sharp traumas are classified into 2, and which are full thickness traumas and partial thickness traumas. And partial thickness traumas cause lacerations. And if there's a full thickness eye wall injury and there's an object in the eye, we call it intraocular foreign body injuries. If there is no object in the eye wall and there's only one wound, we call it penetrating. And if there's an entry and exit wound, we call it as perforating injury. So of course, we again classify the traumas according to the injury site. If the injury site is most anterior at the cornea, we call it zone 1 for the open globe injuries, of course. And if the trauma is between limbus to 5 millimeter posterior to sclera, then we call it zone 2 injury. And zone 3 injuries are the injury site located posterior to 5 millimeter from limbus. Initial evaluation is also extremely important. First, we have to rule out life-threatening injuries before starting the ophthalmic examination. Evaluation and history of events is also should be detailed as much as possible, including time, type of the injury, past ocular history, including visual acuity prior to the injury, and also all the previous ocular surgeries in that eye and the other eye should be noted also. Tetanus prophylaxis, immunization history also should be noted. And then we will document and photograph everything for the follow-up and for the medical legal issues after full ophthalmic examination, including the fellow eyes status. In the ophthalmic examination, we have to be aware of multiple injuries to ocular tissues and surrounding tissues. Avoiding pressure on the traumatized eye is also crucial, especially in the open globe injuries. And we have to do the evaluation step by step, starting from the most anterior part of the eye and its nexus to the most posterior part of the globe. When there is large periorbital ecchymosis or like severe eyelid edema or because of pain, all these factors may preclude adequate ophthalmic examination. Then CT in any case should be used to evaluate the extent of the trauma. assessment of ocular motility is useful in most of the cases to understand the extent of the trauma, but it should be avoided in open glove injuries. Examination, of course, initial best corrected visual acuity should be taken. It's one of the best predictors of final visual outcome, as stated in the OTS score. Here we see it. Also, RAPD is important to indicate the retinal detachment or optic nerve damage. And also, it's one of the factors of the OTS score to predict the visual prognosis. Intraocular pressure should be taken, but applanation tournament may be avoided in open glove injuries, of course. And if there is hypotonia, it may indicate open glove injury. Also, normal but lower IOPs also may indicate open glove injuries, as UL prolapses may have blocked the wound, but still the intraocular pressure is low. In the OTS score, also glove rupture, endophthalmitis, perforating injuries, retinal detachments, other than the best corrected visual acuity and RAPD, are important factors to predict the outcomes of the trauma. But in any case, even the OTS score is low or very low or extremely low, we have to do whatever we can to save the eye, because sometimes there are good surprises in trauma cases. One type of the trauma is, as we said, blunt trauma. There's a direct impact, but other than direct impact, there's a compression wave force. We call it the countercoup damage. Also, there's reflected and rebound compression wave forces. And other than that, there's an indirect force from the bony walls and other orbital content to the glove. So it's a very severe type of trauma. There may be conjunctival wounds. There may be subconjunctival hemorrhages masking the occult scleral tears. There is very commonly, there is a traumatic hyphema, which may require extensive intraocular pressure and inflammation control. There may be pupillary complications, lens complications, angle recessions, which may be evident in a gonioscopy or at the UBM imaging. There may be anteriorly located scleral ruptures. Also, there are posterior segment complications of blunt trauma, vitreous hemorrhages. When there's a vitreous hemorrhage, there's like a great chance that it's associated with another retinal pathology. Also, commotio retina is very common. It's 30% of all eye traumas presenting to the hospital treatment. There may be choroidal ruptures. There may be acute subretinal or choroidal hemorrhages at the time of the trauma. Other posterior segment complications, such as retinal breaks, detachments, vitreous base avulsions with dialysis, equatorial breaks, macular holes, traumatic optic neuropathies, and also optic nerve avulsions are not can be observed in blunt trauma cases. Another type of trauma is penetrating trauma. There may be penetrating corneal wounds, which we call them zone 1 injuries with a zedal positivity. Narrowing in the anterior chamber with iris involvement is one of the evidences that there may be a corneal wound. There may be scleral lacerations, and we have to always check if there's a corneal limbal laceration or any kind of wound. We have to be sure that it's not extending posteriorly, and we have to explore the eye as soon as possible. There may be iridociliary or vitreous prolapses, which we may have to take care of, and most importantly, primary closure of the eye should be done as soon as possible to avoid endophthalmitis. With the penetrating trauma, anything can possible. There may be hyphema, there may be lens damage, and if the lens capsule is ruptured to the extent that we cannot repair it, the lensectomy should be performed during the primary surgery. There may be also vitreous hemorrhages with that type of traumas. In order to not to overlook occult scleral tear, there are some cardinal signs. We have to search for them. For example, deepening of anterior chamber with posterior iris retraction, relative hypotony, extensive chemosis, vitreous hemorrhages. These are the main signs that there may be scleral tear, which we are overlooking or which we cannot see due to other factors. In that case, the CT, a very controlled ultrasound and UVM can also indicate or show us the scleral tear. Another type of mechanical injuries are intraocular foreign body injuries. They can be due to metallic foreign bodies with active metals such as iron, copper, or with inert materials. So there's a physical impact of the foreign body, but also with the active metals, there is a toxicity in the short or long term, causing siderosis or calcosis. With the non-metallic foreign bodies, there is they can be with inert materials such as glass, or with unstable materials like wood or like plant thorns, and with them there's a greater chance of causing endophthalmitis. Here on the right hand side, you can see a case that is followed as chronic uveitis, unresponsive to immunosuppressive treatment, and as it is shown in this video, there is an entry wound in sclera, and the thorn is located in between sclera, and it's just one part of it is in the vitreous cavity, causing a chronic endophthalmitis. Intraocular foreign bodies can also cause hypotonia, vitreous opacities, retinal choroidal tears, detachments, or hemorrhages, and they can be located almost anywhere in the eye. Here in this case, on the right-hand side, you can see that the entry wound located temporal to the macula, and just beside it, the foreign body is located under the retina in the choroid. So the entry wound is very much posterior to the eye. And in order to take out these intraocular foreign bodies, we need to elevate the retina and the choroid for an extent. And then here, as in this case, because the patient was phakic, the foreign body was removed through a subpleural tunnel incision. To detect intraocular foreign bodies, we may use X-rays, ultrasonographic imaging is especially useful to detect non-metallic radiolucent foreign bodies. Of course, CT is extremely useful in those cases. Here is another case of an intraocular foreign body, but what is important about this case is that this is 1 week after the trauma, and there's an anterior chamber reaction, there's vitritis, and there's an ongoing endophthalmitis in this case. So we, after we extract the intraocular foreign body, we inject intravitreal antibiotics and a silicone oil injection to treat this case. And you can see that relatively large intraocular foreign body is taken out through a subpleural tunnel. And after the subpleural tunnel closure, we continue with the silicone oil injection and intravitreal antibiotics, of course, with systemic and topical antibiotic coverage. So post-traumatic endophthalmitis is extremely important in the treatment of trauma cases. It's an important prognostic factor in all ocular trauma scoring system. 20 to 30% of all endophthalmitis cases are post-traumatic, and they have a higher instance than post-operative endophthalmitis. Of course, the risk factors of post-traumatic endophthalmitis are late primary closure surgery, but as in this case on the right-hand side, they can happen in the first 12 or 24 hours after the injury. Here you see how fulminant is the endophthalmitis. When there's an intraocular foreign body, when there's a trauma in rural setting, or like objects contaminated with foodstuff, pet injuries, wild animal injuries, they have a higher chance of these fulminant endophthalmitis, especially soil and contaminated cases with bacteria of high virulence, such as Bacillus species, can cause endophthalmitis in a very early stage of the injury. Of course, if there's a lens capsule rupture, there's a higher chance of post-traumatic endophthalmitis. Also, type of injury, the wound site, for example, there's like a large wound. If there's a vitreous or uveal prolapse, there's a higher chance of getting an endophthalmitis after the trauma. 65% of the time, there's a gram-positive agent, but with soil contaminated cases, Bacillus species, Pseudomonas, and Clostridium species can be detected, and they have a very high virulence, and they have to be treated immediately. With plant injuries, fungal endophthalmitis are a little bit more common. So endophthalmitis prophylaxis in open globe injuries should be done, and it's extremely important. Only the way of administration of antibiotics may vary according to the type of injury. So how do we do it? So after the primary repair surgery, if there's no intraocular foreign body in the eye, we may prescribe antibiotics intravenously, orally, or topically. But if there's a high-risk case, what's a high-risk case? We already talked about it, but if the primary closure is done lately, or if there's a lens rupture, if there's like prolapses of intraocular structures, if the wound site is large, if there's a contaminated wound site, and if there's an intraocular foreign body in the eye, then intravitreal injections or broad-spectrum antibiotics is justified, along with the, of course, oral and topical antibiotics. So regarding the steroid treatment, there is no consensus regarding its usage, timing, and dosage, but in general, it's highly recommended, and the timing for that is probably as early as at the time of the surgery, or 12 or 24 hours after the initiation of antibiotic treatment. So thank you for listening.
Thank you, Murat, so much for such an interesting talk, very important notes. We will have the chance to discuss your presentation at the end of this session of this section of the webinar. Now, I would like to welcome our second speaker, Ranko Gvozdenovic from Belgrade, Serbia, who will discuss the red eye emergencies. Thank you.
Dear colleagues, thank you for this kind invitation. My name is Ranko Gvozdenovic, and greetings from Belgrade, Serbia. I will talk about red eye emergency, step-by-step approach. This is a very big and huge subject, so I will give you just a brief approach of red eye definition, its significance, classification, good ways to do examination, anamnesis, and clinical approach, and also some practice guidelines step by step, and maybe some possible outcomes. Red eye is a condition where the white part of the eye sclera appears red due to inflammation or blood vessels, dilatation, and understanding red eye is crucial because it can be a symptom of various underlying conditions, some of which may require immediate medical attention. Its significance is one of the most common presentations to primary care and the emergency department. It can be often misdiagnosed, which can lead to severe sight-threatening conditions. It's a very wide field of causative possibilities, and certain clinical experience is required. It is required to do a good anamnesis, and examination is a key to an accurate diagnosis. We say that a good anamnesis is half of diagnosis, and thorough history is essential, as the presence of the red eye may be associated with underlying systemic disease or overlooked trauma. Therefore, a complete history, including a systemic review, past medical, drug, family, and social history is necessary. Very important question is there any pain or is there any loss of vision? So we need to see if it is unilateral or bilateral, duration of the symptoms, presence of photophobia, recent eye trauma, surgery, contact with anyone ill, history of contact lens uses, or if so, contact lens hygiene, contact lens wear, trauma, corneal surgery, ocular surface disease, systemic disease, immunosuppressions. They are all predisposing factors to alter the defense mechanism of ocular surface. In the clinical approach of diagnosis, both macroscopic and a slit lamp examination is important. In macroscopic examination, we can quickly see if there is an eyelid asymmetry, if there are any proptosis, eyelid swelling, how are extraocular movements, if necessary, to see if there is a monocular, binocular diplopia. To see complete conjunctiva assessment is sometimes easier and better with the microscopic approach. After that, visual acuity with the monocular approach, sometimes, if necessary, pinhole assessment, to see how are pupils, is there symmetry in pupils, and to see a pupil's reaction, is there any afferent pupillary defect. External eye to see anatomy of the eyelids, eyelid margins, blepharitis signs, is there any swelling, how are eyelashes, anatomy and positions, to see complete tarsal, fornix, and bulbar conjunctiva examination, especially in foreign body if foreign body is present, and trauma cases, type of injection, conjunctiva, hemosis or ischemia, how are episcleral blood vessels, very important in some orbital or orbital trauma or pathology or glaucoma pathology, to know a difference between papillary versus follicular conjunctivitis. Is there any inflammatory cells, hypopium or hyphema inside the anterior chamber, foreign bodies in the cornea, epithelial and stromal defects, infiltration, edema, precipitates all layers of the cornea, and after that, the fluorescein dye to measure intraocular pressure. Always think about steroid treatments, acute angular closure or inflammation. After all of that, a good fundus checkout. Red eye etiology, it is a very big subject, but it can be divided like this, or it can be divided in traumatic or non-traumatic red eye. What about infection? It is, of course, keratitis, conjunctivitis, or endophthalmitis. All kind of allergy conjunctivitis or blepharokeratoconjunctivitis. Trauma cases, we'll talk about that, inflammation in all parts of the eye, raised intraocular pressure, especially in acute angular closure or other, for example, dry eye. This is like a scheme, a step-by-step approach in a non-traumatic red eye. Very useful. Patient with red eye, is there any pain or no pain? In case of mild or no pain, if there is a hyperemia, if it is focal, we think about episcleritis. If it is diffuse, we see if there is discharge or no discharge. No discharge, subconjunctival hemorrhage, continuous discharge. If it is purulent or mucopurulent, we think about bacteria. If it is watery and associated with itching, we think about allergic or viral conjunctivitis. If there is no discharge, we think about blepharitis, dry eye, of course. If in the beginning there is a moderate to severe pain, we need to think about different things. The presence of corneal infiltration, of course, there is a keratitis, microbial and some other marginal keratitis, presence of corneal epithelial defects. We think about herpes simplex, epithelial keratitis, of corneal abrasion. If there is a raised intraocular pressure, we think about glaucoma, or we think about inflammation and scleritis, any kind of uveitis and endophthalmitis. This is a way of thinking. In the non-traumatic red eye, it is always very useful to see if what kind of discharge it is, or it is follicles or papilla. Follicular reaction, it is a raised area of inflammation around the vessel. Like on the picture, it is toxins, viruses, or chlamydia. If it is chronic, we need to check the eyelids for molluscum contagionosum. If it is a papillary reaction, it is raised area of inflammation without a vessel. We can see it in allergic, any kind of allergic cases, foreign body, including contact lenses, of course, and superior limbic keratoconjunctivitis. If there is a watery discharge, usually with lymphadenopathy or flu symptoms, we think about viruses. If there is a purulent, mucopurulent, hyperpurulent discharge, we think about bacteria or chlamydia. If there is a watery mucoid discharge, we think about allergies. What about traumatic red eye? There is a famous, of course, Birmingham eye trauma terminology system with open and closed globe injuries. Closed globe contusion and lamellar laceration, ruptures and lacerations in open globe. What are the trauma complications? Anterior segment complications of blunt trauma. It is hyphema. We need to see how big it is to know if it is conservative or a surgical approach. We don't want to have a hematocornea. Sphincter tear, very important for the future operations. Iridodialysis, to recognize it. Osseous ring, cataracts, of course, lens subluxation. Always think about raised intraocular pressure. Angular recession, usually overlooked. We need to think about that. Rupture of the globe can be misdiagnosed, of course. You need to do a good ultrasonic examinations. Flat anterior chamber. If we have a flat anterior chamber, we need to expect to find a place where there is a leakage. It can be underneath the conjunctiva. We need to do it in the operating room. Uval prolapse and damage to the lens and iris are emergency cases. In vitreous hemorrhage, we need to check it often because of the retinal tears and ablation, of course, traction retinal tear, and always to put a good medications, proper medications to avoid endophthalmitis. This was a very brief overview of the classification of possible causes of the red eye in daily clinical practice, as well as some recommendations for a systemic approach. This is a huge subject and a big area, and I do it briefly. Getting an accurate diagnosis can be challenging and a frequent source of errors that can lead to permanent vision loss. And following futures, some red flags may be indicative of serious underlying pathology. Reduced vision or vision acuity, deep pain in the eye or tenderness or on palpation of the globe, photophobia, unequal pupil or abnormal pupil reactions, high velocity of the symptoms, or chemical injury, of course, contact lens users, fluorescent staining, and neonatal conjunctivitis. We need always help of our colleagues, and the good cooperation between different subspecialty departments is needed. Thank you for your attention. These are my references, and big greetings from Belgrade, Serbia, and thank you for this kind invitation.
Thank you, Ranko. We will have the chance to discuss your presentation at the end of the webinar. And I would like to welcome our third speaker, Imane Tarip, who will discuss painless visual loss. She won't be able to join us for the discussion part, but at the end of her presentation, you will find her contact email. So please do not hesitate to send her your questions.
Hello, everyone. My name is Iman Tarib. I am an ophthalmologist trained in Morocco and currently a cornea fellow at Illinois Eye and Ear Infirmary at UIC in Chicago. Today, I'll be talking to you about painless visual loss. To start off, I have no financial disclosures today. And so let's just jump right into it. Let's say you're on call, it's 2 a.m., you're trying to sneak in a little quick nap, and all of a sudden you have this new consultation. The patient's complaint is painless visual loss. Where to start? The very first thing is, of course, history and physical. And the way I look at it is walking into the room of the patient is a great opportunity to gather some information even before talking to them. Things such as gender and age, how the patient is looking, if they're having any changes in their facial expression, all of those things would be really important clues. Another thing is asking the patient about the onset. Has the visual loss been happening in the last few minutes to hours or a little more than that? Is this visual loss monocular or bilateral? And also, has it been transient, meaning the patient had the visual loss, but now the vision is back to normal, or has it been the same since it started? The degree of visual loss is extremely important. A no light perception patient is very different from one that has a few lines of difference in their visual acuity. You, of course, have to ask about history. What's really pertinent here is history of trauma, diabetes, really any type of vascular and cardiac disease, or any known ocular history as well. The way I like to look at it is dividing things between monocular and bilateral causes. And we'll walk through all of these causes right here. And I'll start with the one that used to excite me the most when I was a resident, and that is retinal detachment. Patients coming in and they're talking about flashing lights. They're talking about their regular floaters all of a sudden becoming dramatically increased. Some patients can describe something such as a veil or a curtain in the periphery of their vision. Some would just say, all of a sudden, I cannot see anymore. And so when you look into their eye, you can see the retinal detachment as this marked elevation of the retina. Sometimes it's sectoral, sometimes it's complete. You can even sometimes identify the tear in the retina that may have been the cause. And something that's very important is to make a difference between a macula on retinal detachment, which is highest level of emergency, versus a macula off. And in all cases, the sooner the surgical repair is, the better the outcome. Another etiology is central retinal artery occlusion. And believe me when I tell you, once you see one, you will never forget it. It is this dramatic blanching of the retina with this really dark cherry red spot macula. Patients usually have some history of embolic or thrombotic disease, and there's really no treatment that truly works, but there are things that are worth trying, such as hyperventilation, paracentesis or medication to decrease the ocular pressure, or even ocular massage. Always check ESR if the patient is old, even though when you suspect giant cell arteritis, usually it is accompanied by quite a lot of pain. However, there could be some cases in which there is no pain. And so I would highly recommend to check ESR, just because the loss of vision in this case can be reversible if we start corticosteroid treatment immediately. The central retinal vein occlusion is also a dramatic appearance that you'll never forget once you see one. It's relatively rare. I have seen a few during my residency, and some of these patients sometimes rarely can also present with a bilateral CRVO. They're usually older patients with history of hypertension, atherosclerotic vascular disease, or hyperviscosity syndrome. When you look at the fundus, there's this blood and thunder appearance with diffuse flame and blood hemorrhage, cotton wool spots, and engorged veins, and sometimes also optic nerve head edema. The CRVO is tricky because it is really dramatic, but then it can be self-resolving, so you do have to wait. However, some patients can develop neovascularization, and they have what we call the 100th-day glaucoma, so close follow-up is very important. Vitreous hemorrhage is when the patient loses their vision, or they see some hand motion, and they sometimes have a previous history of trauma or diabetes or some type of vascular disease. When you look at them, there's a decreased red reflex before you go into their fundus exam, and you can visualize the hemorrhage on the fundoscopy. It's very important to do a B scan if it is a total hemorrhage to rule out a retinal detachment or even choroidal detachment sometimes. Sometimes vitreous hemorrhage can clear spontaneously, so you have to wait it out a little bit if there is no retinal detachment. But if it is not cleared by 3 months, then a vitrectomy is necessary. AMD, age-related macular degeneration. Sometimes it is the initial encounter of a wet form that comes to your call night. Sometimes it is a patient that is known for having dry AMD and that are transforming to the wet form. Patients come in describing wavy lines or seen underwater, and this is what we call metamorphopsia. Submacular hemorrhage can be caused by neovascularization as well. Having an Amsler grid in your on-call kit is really important. It's one of the things that I used to do very, very first in my exam. I would just hand one to the patient and say, hey, do you see the lines are correctly parallel to each other, or is it really all over the place? And that sometimes can help you know the etiology is from the macula. Some treatments are intravitreal anti-VEGF, but also there is so much exciting research going on. I highly recommend that you go and look into it on clinicaltrial.gov. Macular hole can be idiopathic. It's usually in female patients with older age. Some patients can have myopia or a history of trauma or ocular inflammation. And there are two different types of classification. One that depends on the size of the macular hole, and one that is more relying on the vitreomacular adhesions and traction status, plus the size of the macular hole. The treatment is surgery with a PPV, which is vitrectomy, and tamponade with or without internal limited membrane peeling. Some of these holes can actually also close spontaneously. So sometimes you may have to follow up the patient a little bit and monitor, and then maybe decide on surgery later on. Non-arteritic ischemic optic neuropathy. It is very important always to rule out a giant cell arteritis, and that would be the arteritic form. However, in non-arteritic ischemic optic neuropathy, patients would have decreased color vision, altitudinal visual field loss. You would see a hyperemic edematous nerve that can be sectoral sometimes, as you see on the photo on the left, where that nasal superior quadrant looking way better than the rest of the optic nerve head, versus the one that we see on the photo on the right, where we have a total hyperemic edematous nerve. So a cardiac evaluation is necessary. Some of these patients can worsen within the first weeks, but there are a few studies that looked into the prognosis and that have found that there could be stabilization versus improvement within the first few months. And in general, prognosis is better in young patients. Intracerebral causes. To me, this is the alarm sign, the ding, ding, ding. I have to work at this patient really quickly because it can be life-threatening sometimes. These are patients that may be having ischemic or hemorrhagic stroke or even cerebral tumor. You would see a patient with bilateral papilledema that tells you there's something going on in the brain, compressing your nerves, and the lesion is usually behind the chiasm. Some associated symptoms that can maybe help orient your diagnosis can be asking patient about numbness, weakness, paresthesia, or any other signs like this. An urgent CT scan has to be done immediately in this case. At the end, if you rule out everything and you really cannot find anything, there are a couple causes that I want you to keep in mind, but I want you to think of them as the absolute last resort. I would say I wouldn't even think about them when I'm on call at 2 a.m. until I work up my patient completely and I eliminate any other cause of their painless visual loss. But one would be hysterical non-organic vision loss or psychogenic, it has a few names where the patient believes they have visual loss, but they really don't, versus malignant, where patients are actually faking their visual loss for secondary gain. So I hope this was a quick workup through what you can think of and what to do when you have a patient coming in at 2 a.m. with painless visual loss. If you have any questions or if I forgot anything, please email me, stay in touch. I'm on social media under Dr. Tarib. Thank you again for the great opportunity, and I look forward to answering some questions live.
Thank you. So even though she's not with us, I need to thank Iman for such a great talk. I think she summarized really very important diagnostics and very important topics. So now I would like to invite our speakers to be online, please, and to turn their cameras on. And I would like to open the discussion for the first part of our webinar. We have one question in the Q&A section, and meanwhile, I would like to invite everyone else. If you have any questions in your mind, please don't hesitate to write them down. So the first question is actually for Murat from Lala from Azerbaijan. Is that necessary to use intravenous or intramuscular antibiotics after high-risk intraocular traumas, or you mentioned only IV oral and topicals? Please, Murat, if you can answer.
Thank you, Yelena, and thank you for the question for Lala. For the high-risk cases, I mentioned actually that we have to proceed with the intravitreal injections. But for the others, if you want to use a systemic antibiotic treatment and it's recommended, we can choose either oral way or the intravenous way. It depends on the patient's general health status and like social security, whatever it is, but one of them can be chosen. But if there is high risk, of course, we would go with the IV treatment. I mean, IV, I was trying to say intravenous, not intravitreal. So intravenous treatment is highly recommended for high risk cases, as I mentioned. So definitely, yeah.
Thank you, Murat. There is another question here, and if you can, I can just read through. So it's for both, I think Ranko and Murat. So our colleague asked about his patient who come to emergency with chief compliant, unilateral red eye, chemosis conjunctival after being hit by blunt object. Patient got a history of absolute glaucoma in that eye, the visual acuity already, no light perception before and after the trauma. So the question is that it is confusing for our colleague how to differentiate between low flow corticocavernous fistulas or orbital compartment syndrome, because the symptom in this patient is very similar and we don't have CT or MRI. I guess you can read through if I was not clear enough in reading. And meanwhile, we have greetings from Egypt, from Passant. Thank you, Passant.
Okay, can I say something? Okay, this is a very thank you for this very tricky and very good question. In this case, there is a tricky two-part. In this absolute glaucoma, we already have like absolute afferent pupillary defect probably. So the most important part to see if there is a part of carotid fistula is to check a good pupil reaction, and also to see the second part is to see episcleral blood vessels. In this case, it is also very difficult because of the hemosis. So the best thing you can do in this case is a scanner of the head. Best to do is magnet, but you need to see if good ultrasound examination. It is very, very important in this case, I think, because any other classical clinical signs are not so useful right now in this case. So maybe ultrasonic examination, and also if it is necessary to do examination in the operating room to see under the conjunctiva.
Thank you for the answer.
Maybe I may add some. They are not definite clues, but the eye movements also are important. If you have full eye movements, like if you have restricted eye movements with a like very tight globe, still I would go for the compartment syndrome. But in this case, we have to chase the cortical cavernous fistula, because the other thing, the compartment syndrome, we can easily deal with. I mean, you can treat it at that moment easily. So if you don't have any imaging, I would definitely do a contotomic condylolysis and then and I hope for the best. And I would just refer the patient to a center where he can do the imaging, because it's not hard to do. I mean, for each resident, that's a must for ocular emergencies.
Thank you, Murat. There is one more question for you in the Q&A. Since there have been reports of hemorrhagic occlusive retinal vasculitis with intravitreal vancomycin, do you still recommend it for use intravitreally, or do you think it should be replaced with another drug?
Okay, we always go with the vancomycin and ceftazidime combination. I mean, I regularly use it, even if there are cases. I mean, it's like a common practice for vancomycin. It's a very broad spectrum antibiotic for like very effective. So my first choice will be vancomycin, definitely.
Mm-hmm. And
because the cases I've shown, like they are extended. Like there was a fulminant endophthalmitis case with like hemorrhagic vasculitis, like exudation, ischemic areas, like white arteries. You cannot just you have to treat it at once. So I will start with vancomycin, and I wait for the culture results and the antibiogram results to see if there is any resistance or something like that to change it. But my first choice is vancomycin combination.
Yes, we also do this combination of cephalosporins of third generation and gentamicin. That's the most usual combination, and it gives a good results. The prevention of the endophthalmitis is very good in this case, if given on time. So this combination.
Thank you so much for the speakers. We have about 20 seconds left, so we won't have time for all the questions to answer. The other one was about the intraocular foreign body and cornea condition. We're not be able to perform in the PPV, but I think we'll need to answer this question later. We need to move on. I would like to thank our speakers from the first section and for the great talks. I think we opened lots of discussions that will continue. And I will have to move on.
Excuse me. Ranko said, did he say gentamicin?
Yes.
I mean, I would go still with the vancomycin, because gentamicin has more, like, as far as I know, like toxicities, even most evident than vancomycin. Of course, it's not like I wouldn't say no, but I would go with vancomycin as first choice.
Okay, yes. If we have some history of kidney problems, we ask patients and then we change to vancomycin in this case. Thank you.
Thank you. I'm sorry, we need to move on because we have our next section. So thank you so much for the great discussion and great talks. And now I would like to introduce the next part of our webinar on sustainability. And I would like to welcome our fourth speaker and first of the second part, Johnson Neo, to talk on sustainability in ophthalmology, current perspectives and future directions. Please.
Greetings to everyone who tuned into the SOE webinar, and thank you to the SOE committee members for the kind invitation to speak about a topic that really lies very close to my heart, which is sustainability in ophthalmology. Today, we will talk through the following items. So first of all, I'm going to give you a picture on how serious is climate change and why is sustainability important. And then I'm going to talk you through the evidences of what do the ophthalmologists across the globe think, and what are the challenges for sustainable practices in ophthalmology. Then I'm going to answer the question, is sustainable practice in ophthalmology safe? Before moving to what can we do as ophthalmologists and what can you do as young ophthalmologists, the future generation of eye surgeons. So first of all, how serious is the problem? We know that the global temperature is increasing year after year. And in 2020, the temperature was recorded almost 20% warmer than that 80 years ago. So that's concerning. And the amount of carbon dioxide level that we have charted in 2020 was also, again, at the end of the chart, you could see exponentially higher than that 50 years ago. And this is just a picture to give you a graphical representation. Now, this is a picture taken from the satellite of the Antarctic Peninsula. And within a month, this is a picture of the exact same location because of climate change. Now, the increase in extreme weather events is really not by coincidence. And we know that the heat waves in Europe these days are 10 times more likely. And on average, we are about 4 degrees Celsius warmer than that at the beginning of last century. And we also know that climate change has a profound effect on health. We know that the UV radiation increases by 2% per degree Celsius as the temperature increases. We know that the UV light increases susceptibility to ocular infection, including hepatic infection, and there is also an increased risk of eye tumors as well as cataracts, as demonstrated by the evidences. And we know that the healthcare sector is responsible for about 5 to 10% of greenhouse gas emissions, and that's significant. And amongst that, we know that cataract surgery is among one of the most commonly performed surgical procedures worldwide. And in 2021, about 29 million procedures were being performed. So when you look into, and if you zoom into cataract surgery, which we perform day in, day out as ophthalmologists, where does the environmental pollution come from? We know that over half of it comes from procurement, and then about 30 to 40% from the building and energy use, and the rest is from traveling. And then, having this picture in mind, we will then talk through how we can optimize each component in order to achieve sustainability in ophthalmology. But before that, many would think that UK, which is where my practice is based in, is at the forefront of sustainable practice in Europe. But in actual fact, I'm very embarrassed to say that in comparison to some countries like India, we're about 10 times more in terms of solid waste generation per cataract surgery. And giving you a more graphical representation, this is one phacoemulsification in my hospital on the left, and and on the right, these are the amount of waste generated for 32 cases in India. And this picture illustrated what Aravind Eye Care System does. They've got 2 surgeries happen concomitantly in the same room, and in the middle, they're prepping for the next patient to have his or her cataract surgery. And do they have higher endophthalmitis rate? We will see. But what I'm trying to picture here is that there is a huge international variability in terms of ophthalmic practices, even just taking an example of India versus UK, where the UK produces about 130 kg of carbon dioxide equivalent per procedure, when India only does it for 6 kilogram of carbon dioxide equivalent. Now, if you think about just carbon emission, even the smallest detail in your cataract pack can make a huge difference. Now, we surveyed the body drapes usage in Austria, and we found that the variability amongst different centers in Austria was up to 70%. So some drapes were small and some drapes were full body length. But at the end of the day, the outcomes were very similar. Now, this is a dear friend of mine, Nicholas, together with Oliver Findel, whom many of you will be familiar with, and they're just sitting on a pile of garbage that were generated from a day's worth of cataract surgery in their hospital. And that picture really speaks very loudly to me. So what do ophthalmologists think globally? Now, we know that the ASCRS had surveyed for more than 1,000 ophthalmologists, and majority had felt that the OR waste is excessive. They were concerned about global warming, and close to 90% of them wanted their medical societies to really advocate for reducing carbon footprint. Similar survey and opinions were replicated across Europe. We know that the ESCRS sent out similar survey, and that majority of them were again concerned about global warming and felt that the OR waste is again excessive. However, there are other issues that were highlighted by these surveys. There is a severe lack of awareness. So about 40% of North Americans and 30% of European cataract surgeons were completely unaware about the environmental impact of the healthcare system and of surgical waste. And there is a general lack of consensus. There is a general feeling that people do not agree on the definition of sustainability, what the priorities are, and the scope of practices are. So I led a study amongst the young ophthalmologists in Europe to look into having a consensus statement. And through that study, we found that, again, there is a non-agreement on the definition of sustainability, but most young ophthalmologists think that waste management and reduction is a key component of that. There is still a lack of evidences in the literature about the safety and efficacy of sustainable practices, and whether or not we are in the pursuit of a sustainable world, we are actually compromising safety. And however, what really is that everyone involved in the consensus statement felt that there is a need for curriculum change. Now, we know that the conventional curriculum does not emphasize on sustainable practices at all, and so that needs to change. And what are the other challenges that is stopping us from being more sustainable in ophthalmology? We know that there are stringent policies and guidelines out there. So for example, these are just examples. The EU medical device regulation says that, for all your IOLs, you need very, very long patient information incorporated into a huge packaging for a small IOL implant. And in the States, the CDC and Association of Perioperative Registered Nurses needed to have sleeve surgical jackets in the OR. And more importantly, when we think about using reusable medicine or multi-dose sort of bottles, there is a lack of evidence for universal infection control policies. So it comes down to a key question here: is sustainable practice in ophthalmology actually safe? Because many hospitals will argue that, yes, we can become more sustainable, but we do not want to compromise on patient safety. We do not want to hike up the endophthalmitis rate. However, just quoting an example of multi-dose medications. So for example, in the UK, your intracameral caparoxime, there is a huge bottle of medication, you made it up, and the nurses made it up, and you can only use it for one patient. And that's a severe waste of medicine, as well as being very environmental unfriendly. So looking into just multi-dose medication, we know that if we use in accordance to guideline where the tip doesn't touch the patient's eyelid or any ocular surface, the probability of bottle tip contamination by setting is really low in the oral setting by a trained personnel. And there are the states about using multi-use solutions in the operating theater. And we know that looking at reusing surgical products, again, India is at the forefront, where the Arvind eye care system really routinely reuses surgical gowns, irrigation bottles, phaco cassettes even, and they don't gown their cataract patients. And their post-operative endophthalmitis rate was 0.04%, and that's equivalent to that recorded in the US IRIS registry, and they've even outperformed the UK in accordance to the rate charted in our UK National Ophthalmic Database. So they are doing really well, and they are still being sustainable. And it comes down to the question, what can we do as young ophthalmologists? And again, I would like to draw you back to this diagram where procurement, building energy use, and travel makes up to the triad of how we can think about being sustainable. And I'd like you to use the analogy of reduce, reuse, and recycle, where, first, if we look into patient means of transport and distance traveled for single procedure in a Viennese hospital. Again, there is a huge variability. You want to really think about whether or not you want to optimize your post-operative regime, whether or not it is necessary for people to travel long distance back to the main hospital where cataract surgery was being performed, or can this post-operative care be outsourced to somewhere in the community, for example, an optom-led service or a community hospital that is a lot closer to the patient, or even utilizing virtual follow-up services such as telephone or video consultation. And then, we look into building and energy use. Again, there are things that we don't normally pay attention to. For example, heating and ventilation in the OR room, as well as the lightings and the IT equipments. So this study really is interesting because it found that there is no difference in airborne microbial load when compared to if you switch on the ventilation for the whole day, or if you just switch it on 30 minutes before your actual list starts. And that's significant because if you do not need the ventilation or air conditioning to be switched on overnight, then that potentially saves a lot of energy. But above all, procurement is a key bulk of where we can really change in terms of being more sustainable in our practices. Now, this is a complex diagram of, again, how RRV and eye care systems save carbon dioxide at carbon emission. And the green ones are the reuse. And the orange boxes are where they recycle or they think about waste management. And you can see that in this complex diagram, again, they are incorporating reuse, reduce, and recycling, the 3R policies that we are very familiar with. And, we talk about variation in your cataract pack sizes. And, we know that the smallest and the largest cataract cap pack can amount to almost 700-gram difference in terms of the carbon footprint. And even small little things like spears, do you actually need them? Do you need that amount of gauze? And do you actually need to shield patients who underwent topical procedures? So these are some of the questions that I put forward for you, and I challenge you to think before your next list. And we know that there is a profound environmental impact by reducing product volumes and cloth sizes. And we know that, if you can reduce if you can have a weight difference of 37% in terms of your cat packed weight, the carbon footprint reduction can be amounted to almost a third. And I'm gonna need to talk to you about #StartNextMonday, which is a great campaign advocated by the young ophthalmologists for sustainability. It challenges your own practice because you're going to be your own boss one day. And what would you do next Monday? Are you going to enable ventilation 30 minutes before surgery instead of switching it on overnight? You're going to use more disposable equipments, or you're going to reduce them? Are you going to replace full body size drape to a face drape? Or you're going to start using multi-dose topical medications? So I'd like you to think about what sustainable practices you can challenge your workplace to adopt, and then post it on your social media using the hashtag #StartNextMonday. And for those of you who are joining the ESCRS conference this year at Barcelona, we would love to showcase some of these great examples that you have. Or you could come and have a look at what amazing sustainable efforts that people have done globally. And I would like to also draw your attention to the iSustain, which is a great initiative started in the States. It's a global coalition of ophthalmological societies for most sustainable practices. And there are and there is a wealth of evidences and resources in their website where you could refer to. For instance, if you're thinking about being more sustainable at your workplace, you want to think about quality improvement projects, but you do not know where to start, you could go to the iSustain website and see what examples there are. If you want to think about quoting examples of evidences for why sustainable practices are safe, again, you could go to the website and find those papers and then read them and quote them as necessary if you need to convince your hospital management to be able to let you do that. And there is also the SCI ratings and the CDIX ratings, which I'm sure is starting to come into the mainstream practices, where you could use the CDIX calculator actually to measure and compare the weight of your cat pack against what we call a gold standard cat pack in Europe. And then, you can look into how you can then optimize whether or not, your cat pack it's way more excessive compared to what a gold standard cat pack is, and how you can then think about initiatives in cutting the unnecessary waste. Now, this is the ESCRS Young Ophthalmologist for Sustainability, and this is an outdated slide where we were advertising for Vienna conference last year, but I will urge you to join the ESCRS Barcelona this year. Come to our sessions and be part of us. So at the end of the day, thank you so much for tuning in. Get in touch with me if you want to collaborate, and #start next Monday. And I'd like to see some of the great examples that you will have for the upcoming year. Thank you.
Thank you, Johnson. We will have the chance to discuss your presentation at the end of this webinar. And I would now like to welcome our fifth speaker, Sila Bal, who will discuss sustainability in ophthalmology, a global perspective. Thank you very much, Sila.
Hello, everyone. My name is Sila Bal, and I actually just finished my Global Ophthalmology Fellowship at the Moran Eye Center. In today's talk, we're really going to focus on sustainability in ophthalmology and magnifying our view for a global perspective based on my experiences over the last year. So the 5 R's of sustainability may be familiar to most of you. I would say that, at least 3 out of the 5 should be pretty familiar to us. But these are the core tenets of sustainability, not just in medicine and not just in ophthalmology, but across the board. So these are reduce, reuse, recycle, rethink, and research. But how can we think about these tenets of sustainability when it comes to ophthalmology? And what have I learned throughout my work in global ophthalmology, working with global communities around the world that have helped shape my understanding of sustainability in ophthalmology? So to start, as physicians, as surgeons, we usually want to know, what do we already know, right? What is the research? What is the evidence out there that supports any claim that we're making? And this is true for really any treatment modality, any physiology that we know, but also for any innovation or any change that we want in sustainability. And fortunately, over the last 5 years, maybe even over the past decade or so, there really has been this shift towards making sustainability a priority and towards better understanding what that means to us in the care field. And, this slide, just a couple of the studies that I pulled out that I found interesting or that kind of stuck out to me. But if you are bored on a Friday night, nothing better to do, you can really go into PubMed and delve deep into this topic. And as with most things, there are some controversial views or some contradictory ideas, and that's normal, right? We're in these early stages of understanding sustainability. So it's understandable we'll have different conflicting ideas or views, but the fact that we have so much information already available to us is extremely exciting and very important for eliciting future change. And now I just want to highlight one study here, and this is a study that compared carbon emissions from phaco-cataract surgery in the United Kingdom versus at Aravind Eye Hospital in India. And for those of you that aren't familiar, Aravind is kind of this model eye hospital that uses efficiency to provide effective and safe cataract surgery care. And actually at this point, all types of eye care. So they have all subspecialty care, but they really started out as a cataract surgery eye hospital. And so they have really honed the art of sustainable cataract surgery. But what this study showed was that one phaco-cataract in the UK generated the same carbon emissions as driving a car 310 miles. Aravind, on the other hand, generated the equivalent of driving a car just 23 miles. So think about that, 310 miles versus 23 miles. That's a 13-fold difference in emissions. So what does that mean for us? How can we reach a place where, maybe it's not the Aravind level of decreased emissions, but where can we meet in the middle, right? Where can we meet so that it's not a 13-fold difference, but maybe a 5 or 7-fold difference? How do we keep waste out of landfills and minimize carbon emissions for each individual surgery? Now, if you go through the literature, there are solutions that show preferences for reusable devices, effective recycling, repurposing instruments, donating used items. All of these can be effective, but I don't have all of the answers to these tough questions, nor do I believe anyone does. All we can do is learn, be better each time, and try our best to move towards a more sustainable future. And that brings me to the second R, recycle, right? This is the R that we all think about when we think about sustainability in any way. So earlier this year, I worked at Tilganga Eye Hospital, and Tilganga is essentially the Nepalese equivalent of Aravind in the sense that they provide effective, safe eye care to communities throughout the country, whether that's low resource communities or higher resource communities in Kathmandu. But as part of that work, I spent some time in Hetauda, which is a small community hospital outside Kathmandu. And then we would go even further out of Hetauda into the very rural communities to deliver care. And during one of those circle outreaches, I have these buckets. And we look at these buckets and we think, yep, that looks like a recycling bucket, different colors, different labels. But I was trying to understand what are we recycling exactly? And what are we doing with those materials? And they said that they are recycling everything from blades and plastics. And what they do is they recycle those, take them to the recycling company, and then repurpose them and use that money to provide free care to communities that they provide outreach to. So this brings me back to another study from that previous slide, which showed that recycling contaminated disposable surgical instruments resulted in a reduction of 505 kilograms of CO2 emissions over 6 months. So that is the equivalent of driving approximately 1,400 miles. Now, I know that some of you may be thinking, yes, but recycling is also controversial. Weren't there all of those kind of, not conspiracies because they were shown to be real, but just the controversy that a lot of the things that we thought we were recycling were kind of getting moved to countries like China and to regions like Hong Kong that weren't necessarily recycling them, and then China kind of banned recycling. And that is all true, right? The recycling supply chain may be imperfect. It certainly is still imperfect. Just because it's imperfect doesn't mean that we shouldn't continue to try to work towards a future where we can recycle our surgical instruments. Others will say, yes, recycling, but that also generates energy use, etc. Absolutely. I agree. We agree, but we just need to find a place where we can recycle in a sustainable way. And in order to do so, we need to put one foot in the other and just start somewhere. Our next R, just coming back to Tilganga, the next R is reuse. So I had to share this picture of a patient who was post-op day 1 following cataract surgery. And you can see that he is seeing for the first time in years and how happy he is. Now, in Tilganga, we reuse all of our surgical instruments. All of the patients get tested for HIV and hepatitis, but then beyond that, we reuse blades for 3 or 4 cases until they're dull. We reuse our gloves for 10 cases. Instruments are cleaned with alcohol in cases and then reused. Now, once again, similar to recycling, it's important to understand that obviously in high-income countries, this may not be a reality, right? There will never be a time when we're going to reuse all of our instruments, clean them with alcohol, and then reuse them on patients. But can we shift the future with more reusable items, right? Can we find a way to decrease our consumables and have a process that safely sterilizes items without throwing everything away? Again, this is studied and supported by the literature. So in one study, switching from disposable to reusable surgical gowns in a single hospital led to a waste reduction of 23,000 kilograms of CO2, saving the hospital $60,000 over a 12-month period. So not only are we reducing waste through this one simple solution, but we're also cost saving. And that's the ultimate goal, right? Make it palatable to leadership, to administration, so that we can move towards a sustainable future. Our next R is reduce. So this is a picture of my husband weighing trash at Chuuk State Hospital in Chuuk, Micronesia. And this after about 6 cataract surgeries generated this one bag. And you can imagine in the US, that one bag would really be multiplied by 2 for just a single cataract surgery. And Chuuk is interesting because I like to think of Chuuk as kind of a model between the care that we provide in the United States and the care that I learned to provide in places like Tilgunga. I really got to set my own standards there and find this mix between sustainability and reusing equipment and also making sure that it's safe for the patient. And one thing I found hugely helpful was reusing bottles of drop. In the US, we often throw away bottles, but we can really reuse so many things that we thought that we have learned, at least in my training, that we don't reuse. And then our final R, rethink. So reduce, reuse, recycle, research, and rethink. I learned so much from every single location that I work in, every single person that I work with. This picture myself with 2 of the female surgeons, Dr. Alina and Dr. Mohini, at one of our outreaches in Nepal. And I can say without a shadow of a doubt, I learned from our patients, I learned from our staff. And so how can we as ophthalmologists rethink our practice patterns to move to a more sustainable future? How can we challenge ourselves to do better with less? And I leave you with that final question to yourself. And I want to thank the whole SOE team for inviting me to give this talk. And then, of course, all of the surgeons, patients, and staff that I've had the privilege of working with over the last year. My contact information is here on this slide. Please don't hesitate to reach out to me at all if you have any questions or just want to talk about anything. I'm always available. Thank you.
Thank you so much, Sila, for such a great talk. Unfortunately, Sila won't be able to join us for the discussion part, but she left her contacts, so please don't hesitate to write to her and to contact her about her speech. And I would like to welcome our next speaker, Maria Antonia Ferrara, who is working in Italy in University of Brescia, and she was working in UK as well, who will discuss sustainability in vitreoretinal surgery. Please, Maria Antonia.
So, good afternoon, everyone. I'm Dr. Maria Antonia Ferrara, Senior Lecturer in Ophthalmology at the University of Brescia. I'm going to speak about sustainability in vitreoretinal surgery. Speaking about this topic, we need to introduce the intraocular tamponates that are defined as non-solid synthetic compounds and are divided on the basis of their chemical structure. In particular, we can differentiate between fluorinated gases, including SF6, C2F6, C3F8, perfluorocarbon liquids, perfluorooctane and perfluorodecalin, semifluorinated alkanes, F4H5, F6H8, silicone oils that are PDMS polymers, and heavy silicone oil that are a mixture of silicone oil and semifluorinated alkanes. This device, these intraocular tamponates are classified by the MDR regulation as a surgically invasive medical device that can be further classified based on the contact duration, the type of contact with the human body, and other specific features. In particular, as you can see, we are mainly speaking about medical devices of class 2A that are intended for short-term use, and that are SF6, PF4, PFD, F4H5, and F6H8, a medical device of class 2B, implantable and long-term. So we are speaking about long-acting fluorinated gas, C2F6 and C3F8, and silicone oil and heavy silicone oil. In order to be approved for the surgical use within the European Union, these ocular endotamponates or intraocular tamponates needs to conform not only to the medical device regulation, but also some ISO standard. ISO stands for International Organization for Standardization. In addition, based on the chemical class and the properties, specific compound can be subject to specific European and or international regulations. But why we are speaking about gases and perfluorocarbon liquid in a webinar on sustainability? This is because it has been proposed at the European level a proposed restriction, a proper ban on manufacture, use, and place on the market of compounds that are called poly or perfluoroalkyl substances, or in the abbreviation PFAS. These, in particular, from a chemical point of view, these PFAS are defined as fluorinated substances that contain at least one fully fluorinated methyl or methylene carbon atom, with a few note exception, any chemical with at least a perfluorinated methyl group or a perfluorinated methylene group in a PFAS. Well, the REACH restriction process is a legal instrument aimed to protect human health and environment from unacceptable risk posed by this chemical. So it's under the area of interest of the ECHA, that is the European Chemicals Agencies. What is the process in particular within the European Union? In January 2023, 5 countries, in particular Germany, Denmark, Sweden, Norway, and Netherlands, submitted a restriction proposal to ECHA, so the European Chemicals Agency. After this proposal started a phase from March to September of public consultations, and where individuals or industries or companies or societies could submit some comments on the proposed restriction to the ECHA for the evaluation, for the subsequent evaluation by 2 specific committees, the Risk Assessment Committee and the Socioeconomic Analysis Committee. More than 5,000 comments have been submitted to ECHA, and now we are in the phase where these 2 committees that we said are analyzing the proposal, are analyzing the comments, focusing on the effectiveness and the socioeconomic impact of the restriction. After that, these opinions, the ECHA opinions, will be sent to the European Commission, and a final decision will be made with the member states at the REACH committee scrutiny of the European Union Council and the European Parliament. In the meanwhile, so between the public consultation and the development of the opinion by these 2 committees, there is also a forum for exchange of information on the enforcement that sent its advice on the topic. Why this is so important and why has been done a restriction proposal for PFAS? These compounds are synthetic chemicals that are also called as forever chemicals and are known to be hazardous for the environment and the human health. Why they are called forever chemicals? Because they are characterized by a very high persistence, and this is because they have this carbon-fluorine bond that is one of the strongest bonds in organic chemistry, so these are very stable compounds. Consistently with this, according to the Risk Assessment Committee, the persistence is the primary concern with the PFAS. So if the release of these PFAS are not minimized, there will be an increasing and irreversible exposure of the environment and humans with the inevitable adverse effect. You can see also here other concerns related with this compound that are the long-range transport potential, the mobility, accumulation in plants, bioaccumulation potential, ecotoxicity, endocrine activity, and the effect on the human health. The use of this compound is wide because of their useful technical properties. In addition, there are more than 10,000 PFAS currently available. What are these properties? They are oil, water, and dirt repellents, resistant to extreme thermic, chemical, and physical conditions, thermal and electrical insulation, and the ability to act as a refrigerant and surfactants. And some of the PFAS use include also the use in medical devices. So when we Another important topic to understand how big could be the impact of this restriction, but also the impact of this PFAS, is that when we need to analyze all the life cycle of this PFAS, considering also the emission of PFAS and the exposure and the waste management, because the contamination can happen at any time of the life of the PFAS. So coming back to the intraocular tamponites, what would this restriction mean for the eye surgeon? A broad restriction would involve most of the compound that we currently use as ocular endotamponites, in particular C2, both the long-acting gas, so C2F6 and C3F8, all the perfluorocarbon liquid, the semi-fluorinated arcades, and on heavy silicone oil, as we said, they are mixtures of silicone oil and semi-fluorinated arcades. So, and to have an idea of the global situation, we need also to consider that SF6, C2F6, and C3F8 are fluorinated greenhouse gases, with SF6 being the most potent greenhouse gas. So, what do we know about the risk assessment? The situation is quite complex because PFAS are not examined separately for ophthalmic use in the restriction report and are not specifically mentioned among the medical devices. So, according to the European Union, nowadays the high number and the lack of information on each substances makes it impossible to assess all PFAS substances by substances, even if now the two committees are analyzing let's say, this compound by sectors, and have provisionally concluded on 4 sectors not involving application of PFAS in VR surgery so far. We also know that the environmental effect of fluorinated gas varies significantly, not only depending on the gas, but also on the delivery system, with the 30 ml canister that could result in a significantly reduction of carbon emission versus, for example, the 75 millimeter and the big cylinder. So we also know, this regarding the PFCL, that these compounds are known to have some contaminants that in particular are oxygen-containing compound and incompletely fluorinating contaminants, and the toxicity of this compound depends on the profile of impurities, among which the chemicals not identified or out of range of the detection level could be responsible for the final toxicity. Euretina participated in the public consultation by sending the comment with the endorsement of 22 national European societies. The main point of this comment was, the aim of this comment was to highlight the baseline situation and the potential impact of the restriction of PFAS used as intraocular tamponade in vitreoretinal surgery. The main point was the irreplaceable role of this compound as intraocular tamponades, the absence of alternatives at the moment, the potential of an unmet clinical need, because the band will need to a compromised quality of care, significantly increase of severely sight-impaired and blind people and job loss due to the involvement of working age population, and a specific contribution of the PFAS for ophthalmic use that is minimal compared to the global production. So Euretina asked for an exemption from the REACH restriction or a time-unlimited derogation to their essential use in VR surgery. In addition, some proposals have been made to switch towards a more environmentally friendly practice, minimizing the emission or use of fluorinated compound. In particular, some active awareness campaign, the promotion of the use of air instead gas when possible, the promotion of the use of concentrations inferior than the isovolumetric one of C2F6 and C3F8 to replace in particular SF6, that is the most potent greenhouse, the promotion of more environmentally friendly delivery systems for the fluorinated gas, and of corporate awareness and collaboration with companies towards a more environmentally friendly delivery system, Also research clearly on alternative on these tamponade agents. Regarding this topic, also the advice on the enforceability of the restriction highlighted some critical issues for the enforceability, in particular the limited numbers of standardized analytical methods and for sample preparation and laboratories, concluding that the proposal in its current form will be challenging to enforce. This point about the analytical method, it's a very relevant topic because we highlighted in several studies the need of appropriate analytic method in VR surgery to test the cytotoxicity of PFCL, in particular because the H value that is a common parameter used and suggests a safety cutoff is not the only parameter that we need to consider, as it has been highlighted the absence of correlation between the H content and in vitro cytotoxicity tests for demonstrated that incompletely fluorinated contaminants are not the only toxic impurity that can be detected in PFCL, and the relevance of biological analysis to highlight this cytotoxicity. As a European expert panel, we proposed a minimum specification dataset to characterize the liquid ocular endotamponates. And with the aim to propose this dataset for the characterization of the ocular endotamponates in terms of their physicochemical properties, purities, and available evidence of safety in line with the ISO 16672. This dataset may raise awareness between vitreoretinal surgery about the properties and lead so to a more informed choice in their practice. You can see the methodology according to the expert panel protocols, and this is the result. So the proposed minimum specification dataset for both perfluorocarbon, the PFD and the PFO, that ask for the specification of the quantification of the known contaminants, the NH value inferior to 10 ppm, the combination of multiple chemical analysis and biological analysis performed to assess the toxicity and safety threshold. Thank you very much.
Thank you, Maria Antonia, for this excellent presentation, an excellent and very interesting presentation. I would now like to invite all speakers to join us for further discussion and questions from the audience. Could you please join us? Thank you.
So I can see that we had some questions in the Q&A part. So I would like our speakers to comment. So in Azerbaijan at my clinic, we're using one phaco cassette systems for the whole day cases between 50 to 70 and no endophthalmitis. What do you think about changing into this practice? And the next question is, in the UK, how far is the Green Hospital model doing in regards of ophthalmic practices? In Egypt, we are going forward with the concept of green hospitals through General Authority for Accreditation in Egypt. I would like to ask our speakers to comment on these two questions.
Thank you for the questions. I think I will start off. It's very interesting because with regards to stories on how different countries have got their sustainable approaches and how that had worked really well without compromising patient safety. I think, the key concept here, and I remember sitting through one of the iSustain session, is that, the new evidences isn't there to force the countries to change their practices immediately, to say that they will have to, because it's safe, to reuse your instruments or reuse the cassettes, and therefore everyone should be doing that. But in order to arrive at that, you will need multiple studies with multiple checkpoints, and then a meta-analysis to prove the safety endpoint. And actually, good evidences like what you have mentioned in Azerbaijan, as well as elsewhere in the globe, it just really highlights the fact that you don't have to do it, but if you do it, it is, up to individual clinicians' discretion. So the cassette analogy could be used also on multi-dose bottles. So just because there are regulations that say there are not good enough evidences to say you can't use multi-dose eye drops, and you should just use minims when intraoperatively, doesn't mean you can't really use multi-dose eye drops. It just means that it's up to the clinician's discretion. So the more clinician discretion, good case examples there are, the more it builds onto the literature that supports further changes in the future. So I encourage that practices to be reported and be shared more widely. And with regards to accreditation, I think in the UK, we're very far behind in comparison to other countries with accrediting sort of hospitals and theatre practices to be more sustainable. But what the movement is in Europe, certainly where I could speak for in terms of ASCRIS, is that there are CDIX ratings that are now going to be given to industrial partners who produces phaco machines, phaco sets, cat packs, to see how green they are in terms of their rating and how that's going to fit into the development of a greener infrastructure. Again, we want to be careful not to greenwash some of this industrial, or when we think about giving accreditation, we want them to be genuine, and therefore, that's the fine balance to achieve, and that's always a difficult bit.
Maria Antonia?
I completely agree regarding the example that I made about the Azerbaijan. The point is that so far we don't have like a strong evidence about like the safety of some different practice and to reuse instrument. And this is obviously a crucial point because of the safety of the patient. The point is that we have many variables also like in the development of infection, and we learned this from antibiotics, for example. It took several studies of thousands of people to demonstrate to have some evidence about the use of antibiotics, topical antibiotics before and after cataract surgery, for example. So we should be also able to standardize several aspects of the surgery in order to get some, let's say, reliable results about this, and for sure it's different. The point is that for sure now we are aware of this need, so we are moving towards at least like the reduction of the carbon footprint. We are now having some data as well, because so far we didn't really know how was the impact on the environment of our surgery. Now we are getting some data, and based on that, we can reconsider maybe all the process also of the patient coming to hospital and like how to arrange our practice also before doing the surgery. It's not only the surgery itself, but there are lots of variables that we need to consider for that. I think we are like starting now, and for sure it will take several years to get to like a different practice and to get some strong evidence about it.
Thank you.
I think in terms of reuse, the surgical instruments or whatever it is, I think we need some medical legal rearrangements. I mean, because in Turkey we are bound medical legally, of course, but still there is reusage of ophthalmic equipment. But if there is any like a legal case, we're bounded. So I mean, if you're going to reuse something properly, we also need to arrange our laws accordingly, probably. It's not just something that we can solely do ourselves, right?
Of course.
Maybe through taxing. I mean, if someone wants to use on his own surgery, like only one-time use equipment, maybe the tax on this guy or the patient would be a little bit higher. I don't know how to arrange that, but probably it will cost someone in terms of carbon dollars, right?
Yeah, I think, Murat, that's a very interesting point. Because medical legal, it's always going to be a hurdle. And the problem is that, you know, no matter how safe you prove, it just takes one infection case to really topple down the whole argument of medical legal protection. Then again, it comes down to the law state, you know, and that's what the movement is about, is making sure that now it's up to the discretion of clinicians and the discussion with the patient, rather than a blanket sort of imposition that, you know, everyone in the UK needs to start reusing the cassettes, or everyone should never reuse a cassette because that is a law. So it should be up to the discretion of clinician, but, you know, that will be a healthy first move.
Yeah, it's a bit like speaking with the patient is not gonna be easy, because it's also difficult to give them like the perception of this. So yeah, for sure, there is lots to do also in terms of awareness of people about these environmental issues.
Any other comments, Yelena?
No, in the Q&A part, I don't see any more questions. No, that's all. I think it was very interesting. And which gas would you use, Maria Antonia, for your patients?
Well, the point about gas is a quite a critical point, because we don't have so many randomized clinical trial or strong evidence again about using air, for example. There are some studies supporting the use of air for specific surgeries like detachment with only superior brakes, but most of the evidence come from retrospective studies. So for sure, I mean, we are now studying also like the possibility to use different concentrations of the greenhouse that are less potent, like so use concentrations that are inferior to the isovolumetric ones, instead of having a different gas dynamics in the eyes. But again, we are now examining all these options. I think for sure we need to investigate more the use of air. That's like a main point that can avoid I mean, this issue, and that could be like a good substitute, but a good alternative. But again, we have no strong evidence, so we need to plan now some prospective studies to investigate this aspect, I think.
Thank you so much.
Okay, thank you all. I think our time is now up. And Yelena and I would like to thank all our presenters for sharing their expertise with us and with all of you, and for the continued support of SOE. Yelena, would you like to add anything?
I would like to thank as well my co-moderator, Murat, and all the speakers and all of attendees for your time and for being here with us. Remember that this webinar is recorded, so you can always come back and listen to all the talks that from today. And it will be shortly available on the SOE website. I would also remind all of you that there will be a very short survey at the end of this webinar, so please take time to complete the survey. And I'd like to thank you all for your time today. And also I would like to remind you that tomorrow we're having another webinar with the very interesting topics of pediatrics, ophthalmology, and artificial intelligence in ophthalmology. And I really recommend that you join the webinar from tomorrow. Thank you.